Good day, everyone. It's a pleasure to welcome you all to the Fistula Care Plus webinar on gender-based violence. This is our second webinar. I am Lauri Romanzi, Project Director of the Fistula Care Plus project. The Fistula Care Plus project is a USAID-funded project that is running from 2013 to 2018. The primary goal is to strengthen health systems capacity for fistula prevention, detection, treatment, and for patient reintegration. With USAID funding, the Fistula Care Plus project and its predecessor projects at EngenderHealth have supported more than 35,400 surgical fistula repairs and have trained over 26,000 healthcare workers. The project is active in Bangladesh, Democratic Republic of the Congo, Niger, Nigeria, Togo, and Uganda, and EngenderHealth also has a separate fistula project active in Guinea. Genital fistula is an abnormal opening in the upper or lower female genital tract that causes uncontrollable urinary or fecal incontinence. Prevalence and incidence are difficult to estimate, and currently the literature shows 1 to 2 million women living with fistula, with 6,000 to 50,000 new cases per year, depending on the source. The causes of fistula vary. Most are caused by prolonged obstructed labor and are called obstetric. This causes tissue ischemia, necrosis, and fibrosis, and is usually associated with many other morbidities. Fistula may also be caused by traumatic injury, which may be due to sexual violence, but may also be due to pelvic crush and pelvic impalement injuries. Fistula may be iatrogenic, mostly from cesarean section, and secondarily, most commonly from hysterectomy and also other pelvic surgeries. Infection and congenital defects may present with fistula, and tragically, end-stage cancer of the pelvic organs may also present with fistula. With that, I welcome you to our webinar on obstetric fistula and gender-based violence, examining the linkages. I'm turning this over to our Deputy Director, Vandana Tripathi. Before joining EngenderHealth, Vandana worked on research related to the quality of maternal and newborn health in sub-Saharan Africa through projects at the Johns Hopkins Bloomberg School of Public Health and the Maternal Child Health Integrated Program. Prior to that, she managed global health programs at organizations such as Health Right International and Planned Parenthood of New York City. Vandana received her PhD from Johns Hopkins University and her Master's in Public Health from UNC Chapel Hill.
Thanks so much, Lauri, and thanks everybody for joining us this morning. So to pull back a bit before we start looking at fistula specifically, gender-based violence, including physical, sexual, and intimate partner violence, remains a massive threat to women's health and well-being. And a WHO analysis looking at GBV prevalence incidence around the world found that substantial proportions of women of reproductive age report physical abuse from an intimate partner at least once in their lifetime. And similar proportions report that an intimate partner has forced sexual intercourse or attempted it in their lifetime. The same study, looking at different countries, found that 1 to 28% of women report physical abuse while they are pregnant by an intimate partner. And this is just IPV examples. And we know that this level of GBV, real, experienced, feared, has profound impacts on health, access to health care, and the effectiveness of health services. When we get to fistula specifically, there are several pathways we can think about that GBV and fistula could be linked. As Lauri pointed out, direct cause, GBV-specific incidents of violence, such as violent rape, can result in a traumatic fistula. But there are also a number of indirect ways that we can envision sexual or other violence leading to fistula. For instance, sexual violence could lead to premature labor, either directly triggering labor far from medical care, where if there is prolonged or obstructed labor, a fistula results, Or GBV may lead to a high-risk pregnancy, one with sexually transmitted infections, one that is too early, one that is inadequately spaced. And then the same pathways to fistula could follow. There's also been theorizing speculation that the experience of GBV, or even its threat, could hinder a woman from seeking medical care, from seeking skilled birth attendance at labor and delivery. So those are a number of causal channels, pathways between GBV and fistula. There's also the possibility of the opposite direction, that fistula could increase a woman's vulnerability to GBV if a partner perceives her as unable to fulfill her relationship role, or by others if she is out of the household, if she's considered in her community to be less protected. So if we want to crudely visualize these different pathways, it looks something like this, where there are a number of potential ways that violence could be implicated in fistula occurring, and perhaps fistula itself could then feed back into the risk of gender-based violence. And these are all potential pathways. When we look at the actual literature, the research that's out there on fistula, almost all of it talks about violence as a cause, a direct cause. In other words, extreme sexual and physical violence that causes a traumatic fistula. And in this literature, almost all of it comes from the Democratic Republic of Congo, where a number of researchers have documented traumatic fistula among women who were very brutally assaulted and raped. So an example is at the Heal Hospital, Longombe and colleagues did case studies of over 700 women who had fistula out of more than 4,700 survivors of violence. And in these case studies, women described what had happened to them. These were traumatic fistulas caused by gang rape, the violent insertion of objects into the genitalia, and even gunshot wounds. Now, notably, another DRC study by Onsrud and colleagues looks at that indirect causal pathway, and this is one of the few studies to do so explicitly. And what they found was that at Pansy Hospital, which sees many survivors of sexual violence in that conflict, had seen in that conflict setting, only 4% reported that sexual violence had caused their fistula. But more in-depth review found that actually only 0.8% of the fistulas were directly caused by forced penetration or gang rape. And what the researchers here found was that among other cases where women reported sexual violence as the cause, the fistula was actually caused by medical error, inappropriate management of rape-induced abortion or stillbirth. Some of them were actually classic obstetric fistulas after prolonged and obstructed labor. And some of the women had indeed been raped and experienced tremendous violence, but had had fistula before that event. So in their conclusions, the authors noted that it appears that sexual violence is more often an indirect cause than a direct cause of fistula. So trying to better understand these pathways, these linkages, one really powerful source of data are the demographic and health surveys. The DHS surveys have been conducted, of course, in dozens and dozens of countries, and they've included modules on gender-based violence since 1998 and on fistula since 2006. Now, the only past analysis of DHS data in GBV was back in 2000, published in 2008, and it took a similar approach as the fistula literature we just looked at, basically treating violence as a possible cause of fistula. A 2009 study found associations between sexual violence and incontinence symptoms, and conceptually treated sexual violence exclusively as something that might lead to fistula. A similar 2007 analysis of DHS data found strong associations between violence and reporting fistula symptoms. And this study suggested that sexual violence might contribute to more cases of fistula than previously understood. So in this context, the DHS data sets really do provide a unique opportunity to look at fistula epidemiology. And since that first 2008 report was done, many more surveys have used the fistula module. So the Fistula Care Project in our first year asked the DHS program if they could conduct a new secondary analysis of all the surveys that have used the fistula module. They graciously agreed, and the report from this was published in 2015, and the link for it is available there. It's on the DHS website. And this report suggested some interesting associations between fistula and GBV. And so this was explored further. And I'm just really pleased that the person who did all of this analysis, Lindsay Mallick, is here with us today to talk about her exploration of these linkages between fistula and GBV. So I'll hand it back to Lauri, who will introduce us to Lindsay.
Thank you, Vandana, and thank you, Lindsay, for joining us today. Lindsay Mallick is a Senior Research Associate for EngenderHealth, seconded to the DHS program. Lindsay conducts research that utilizes data from DHS and SPA surveys on topics such as maternal health, family planning, gynecologic fistula, and health services. She has a Master's in Public Health and International Health and Development from Tulane University and served in the Peace Corps in Mauritania, West Africa. Lindsay, thank you very much for joining us today.
Well, thank you so much for the introduction, and thanks to EngenderHealth and Fistula Care Plus for inviting me to speak today. I still don't see where to show my screen here.
Sorry. Lindsay, if you want, you can use, we have the slides up and we can show the
advance
slides.
them as you go through, if you don't mind.
Sure, no problem. Well, before I get started, I just wanted to say what a wonderful experience it's been to work with Vandana on this study. Her expertise has really guided the interpretation of our analysis and helped to link our results to the big picture policy and practice implications. And I'm really excited to hear her talk more about that in just a bit. But for now, she's done such a good job with the introduction, so I'll just go right ahead and jump into the analysis. So the data for our study come from 12 nationally representative household-based DHS surveys. These were located in 11 countries in sub-Saharan Africa and Haiti, which gave us about 170,000 women ages 15 to 49. We chose these countries because they did include these standardized questions or modules on both fistula and domestic violence. And for the domestic violence module, it's only one woman per household who is interviewed, and it's typically only one woman in every other or every third household who's selected to participate. So we also only use data from women who were interviewed in private. So that gave us a total of about 90,000 women for our analysis. Next slide, please. Next slide, please. Thank you. And so I just wanted to, go back one, sorry. Thank you. I wanted to briefly go over the measures that we used in our study. So our dependent variable was symptoms of fistula, and that was based on the question in the module that reads, have you ever experienced a constant leakage of urine or stool from your vagina during the day and night? So this became our binary outcome variable, but we also excluded women with missing or don't know responses from the analysis altogether. They weren't part of either the numerator or denominator. So for our independent variables, our key variables were gender-based violence variables. So we looked at lifetime experience of either physical or sexual violence, and we also looked at recent experience or violence that happened within the 12 months prior to the survey for both physical and sexual violence as well. And then we were curious to look at the perpetrator of the first act of sexual violence. So this was categorized as either having no sexual violence or sexual violence first committed by a partner, which included husband, former husband, or boyfriend, or sexual violence that was first committed by a non-partner. And that really was everyone else, so relatives, in-laws, friends, acquaintances, employers, coworkers, teachers, religious leaders, strangers, police, soldiers, or other. We also included a variable for terminated pregnancy, any pregnancy that did not end in a live birth, including miscarriage, abortion, or stillbirth. We included parity, so the number of live births, either 0, 1 to 4, or 5 or more, and other demographic covariates like marital status, residence, age, education, and wealth. We had several steps to our methodology. So first we looked at the individual surveys and examined for the prevalence of fistula as well as the self-reported cause. We adjusted for the survey-specific sample design and used survey-specific weights. Then we pooled the data into one data set. Since the sample size in each country really varies by survey, we didn't want surveys with larger samples overly influencing our results. So we weighted each survey equally. So the individual weights were either weighted up or adjusted down so that the total of the individual weights for each survey was the same. And then we did this using the domestic violence weights. And those domestic violence weights account for the probability of being selected to participate in that interview, but also at the survey level, they ensure that the domestic violence subsample is still nationally representative. For the last piece of the methodology, we examined for bivariate relationships and then conducted a series of 3 logistic regression models that measure the relationship between fistula and these violence variables, lifetime experience of violence, recent experience of violence, and perpetrator of first sexual violence. One thing we were curious about exploring was whether or not violence was occurring after the onset of fistula, but since we don't have the exact date of onset for either fistula or violence, we do know that a woman delays seeking treatment for fistula and perhaps lives with fistula for many years. And if we looked at women who had experienced violence within the 12 months prior to the survey, we could possibly make the rough assumption that fistula had occurred prior to that recent violence. So we also, for these last 2 models, excluded women who reported sexual violence as the cause of their fistula. And this was just our best possible attempt to address temporality while working with what we have available in our surveys and data sets. So for our first results slide, we see the percentage of women reporting symptoms of fistula by country and overall. And within each country, like I mentioned, we use the survey weights, and overall we use the pooled weight. But this slide and these results include all women in the surveys, not just women who participated in the domestic violence module. So we found that 0.8% of women overall reported fistula, and that ranged from 0.4% in Cameroon and Nigeria to 1.5% in Comoros and 2% in Uganda. Next slide, please. And here we have the self-reported cause of fistula, also by country and overall. Among all of these women, delivery is the most frequently cited cause. It's about 5% overall. It was as high as 83% in Kenya, 77% in Malawi, and 76% in Zambia, but it's much lower in Comoros and Mali, 34% and 25% respectively. Although these 2 countries do have larger proportions of women with missing information or who say they don't know or who listed other unspecified reason as a cause. And I want to highlight that overall, in line with what we saw in previous research, about 5% of women report that sexual violence is the cause of their fistula, but it was about 11% in Mali and 10% in Cameroon, but not at all reported in Sierra Leone or Tanzania as a cause. So the cause really does vary by country. Next slide, please. So for our last results slide, I'll present the adjusted odds ratios of self-reported symptoms of fistula by violence. And this is just a simplified way of showing these odds ratios instead of a big long table of our results. The results from Model 1 are on the left in light green, and Model 2 is in the middle in medium green, and Model 3 is on the right in dark green. And The reference categories for each of these key violence variables was the no category, or never having experienced violence, and the blue line in the middle is just another way of visualizing this reference point. So in the first model, we found that both sexual and physical violence, lifetime experience of these two types of violence, was significantly associated with having fistula. So the odds of reporting fistula symptoms are 60% higher among those who experienced physical violence and 90% higher among those who had experienced sexual violence compared to having had neither or no violence in either of these categories. In our second model, again excluding for women who reported that sexual violence was a cause, we found that sexual violence that occurred in the 12 months prior to the study was still significantly associated at the same magnitude as in lifetime experience of violence in the previous model, but physical violence that occurred in the 12 months prior to the survey was no longer significant. In the last model, where we stratified by perpetrator of the first act of sexual violence, we found still that sexual violence committed by a partner was significantly associated with having fistula symptoms. But even higher were the odds of having fistula symptoms if a woman whose first sexual experience was committed by a non-partner. So the odds were almost 5 times higher for these women compared with women with no history of sexual violence. And then in all 3 models, we controlled for those cofactors: marital status, residence, wealth, age, education, terminated pregnancy, and parity. And the only cofactors that were significant across all 3 models were age, parity, and terminated pregnancy. So women with a terminated pregnancy, older women, and women with higher parity were more likely to report fistula symptoms than their respective reference groups of no terminated pregnancy, younger women, or no children. And next slide, please. Thank you. So I want to go over our few strengths for this study. We are so lucky to have the DHS surveys, which are both nationally representative and contain these standardized questions, which allow us to draw country-level conclusions and compare across countries, as well as pool data. And when we pool these data, we're enabled to look more in depth at these rare events like fistula. So multivariable regressions don't necessarily have enough power to detect associations if we'd conducted them at the country level, especially when we disaggregate in the way we did. So this was the first pooled analysis, to my knowledge, with a focus on fistula and GBV that also examines by types of violence, timing of violence, and the first perpetrator of sexual violence. So we do have a few limitations. The first and major one being that this is based on self-report of fistula symptoms. So there really isn't any confirmed diagnosis, which could really lead to women overestimating fistula, particularly if they report other types of incontinence that may not necessarily be caused by fistula. We have several types of bias potentially present. First, there's selection bias. Because this survey, it's a household survey of women of reproductive age, we may not capture all women with fistula, like older women or women who have been forced to leave their homes because of the shame that's associated with having fistula. Second, there may be some recall bias when reporting gender-based violence. And third, the social desirability bias may prevent some women from reporting both domestic violence and fistula. Another limitation is that we don't have the date of onset for fistula or violence, so we can't say definitively which came first. And because of the structure of the questions in our domestic violence module, we can tell whether a woman has had recent violence and lifetime experience of violence. We can also tell whether a woman has had experience in her lifetime of any type of violence, but not violence in the last 12 months, but we can't necessarily tell if a woman has only experienced violence in the 12 months prior to the survey. So finally, there are some downsides to pooled analysis. For example, we do lose our country context. And even with our pooled analysis, because fistula is still so rare, we still are limited by a sample size. So where we wanted to look at current fistula, for example, because there is a question in the fistula module about repair, we were just still too limited by too few cases. So that's all I have. Thank you so much. I'll turn it back over to Vandana.
Thank you so much, Lindsay. And I think
This is Lauri. Thank you very much, Lindsay. We're going to, I'd like to remind the participants that at any point you may go into the chat field and enter questions. We are going to have Vandana take us through some of the implications of this data and then open it up for questions. So if you've not already begun, please do begin to enter your questions because we're about to get to that part of the conversation.
Thank you so much, Lauri. Thank you so much, Lindsay. And I really just want to commend Lindsay for taking what was a very, very dense analysis, a thicket really of variables and potential relationships, and really distilling it to that one slide that's showing us that if you've ever experienced physical violence, you have a 60% increase in the odds of reporting fistula symptoms. And if you've ever or recently reported sexual violence, you have a 90% increase in those odds. And that's adjusting for all these other social characteristics that Lindsay talked about. So we're seeing this significant, strong, persistent association between GBV and reporting fistula symptoms. And when we start to think about, well, what does this mean? What do we do with this information? For us, we really did want to try to understand, is this cause or is this effect or is it both? And as we looked at the beginning of the webinar, the prior literature on fistula, if it's looking at violence at all, it has really looked at traumatic fistula. And the findings of this analysis help us, I think, shift that understanding of violence only as a direct cause of fistula to more of a vulnerability or an exposure that is concurrent with fistula or maybe aggravated by it. And what that means is that perhaps having a fistula increases a woman's risk of experience violence, or the same women have the same shared vulnerability. In other words, the same women may be at increased risk of fistula who are at increased risk of GBV. And of course, as Lindsay said, the thing that made this very tantalizing and been very challenging for us is that we can't really assess temporality, because in the DHS surveys, we know whoever experienced physical and sexual violence, we know who experienced it in the last year, but we just don't know for which women this was new incident violence, so therefore we can't really break cause and effect down. It's possible that if future surveys refined how those questions about the timing of violence are asked, we might be able to get at this. But as Lindsay also mentioned, fistula is thankfully still a rare event, and sample sizes are always going to be a limitation. And I think if we're looking at the kind of research that's needed, it's probably qualitative research that explores the timing and the severity and the perpetrators of GBV in relation to fistula incidence. In other words, even if women who have fistula experienced violence before the fistula happened, did that violence change? Did it become more severe? Did it become more frequent? Now, the potential research, these sort of causal hypotheses, it's all very interesting to us, but I think that what's more important right now is that the analysis that we've seen has implications for public health programs, for fistula programs specifically. I think this kind of analysis tells us yet again that healthcare and social and behavior change communication programs need to think about a shared vulnerability framework that incorporates GBV, fistula, lack of access to maternity care, and perhaps other gender-based health issues like female genital mutilation or cutting. That there is a underlying stratum of gender norms, perhaps socioeconomic issues, that increases all of these vulnerabilities, and to think about how these vulnerabilities overlap and contribute to each other. Specifically, how do these vulnerabilities hinder women's access to or reduce the effectiveness of the health services that we try to provide? Coming back to Fistula Care Plus and other fistula programs around the world, I think there are more immediate implications. Research has actually shown, even though we speculated at the beginning that maybe women who experience GBV are less likely to seek skilled care at birth. Maybe that they're hindered, they can't make that independent decision to seek care. But actually there's a lot of research that shows us that women who've experienced GBV make more use of health services. And this makes sense, unfortunately, if there are injuries, if there are reasons to need medical care. So even though women who experience GBV are coming to health services, GBV is often treated as a social issue, something that's separate from public health or from medical issues. And clinicians are often not adequately trained to talk about it, to diagnose it, to manage it. So one implication I think that we take very seriously at Fistula Care Plus of this analysis is that fistula programs should consider routine screening for GBV at intake when women are coming in for fistula repair, and also before discharge when they're planning reintegration. Fistula programs often think about reintegration issues in that women have been stigmatized, maybe they haven't been living with their families, what does it mean to go back to their communities? But I think the analysis Lindsay has shown us is that reintegration also needs to think about violence and whether a woman is going into a situation where she is at risk for sexual or physical violence. And there are obviously ethical implications of screening for something if you don't have comprehensive services to take care of it, or any services in many settings. But the analysis findings tell us that this population does meet the WHO criteria for routine screening, because we have evidence of an increased risk. And I think, of course, the other implication is that in low and middle income country settings, GBV services just have to be expanded and strengthened more generally. So those are some of the implications that come to mind for us when we look at the findings that Lindsay has shared with us. And I think I'm going to now hand it back to Lauri to lead us into the discussion portion.
Thank you very much, Lindsay and Vandana. So now is the time, please, to identify yourselves in the chat box and begin to enter your questions. And I'd like to refer us back while we're waiting for questions to come in to slide 20, the limitations. Some of you may be clinical, and even particularly for those who are not clinical. Again, the demographic health survey model is a survey-only model, as Lindsay pointed out. There is no examination of the patients to confirm that their symptoms are caused by a fistula. And those of us with a clinical background understand that prolonged obstructed labor lasting 2 and more days will cause some sort of at least transient lower urinary tract or rectal dysfunction, very often incontinence, and that may and very often is permanent and severe. So it's important to understand that particular limitation, because what we really don't know from this data, though it is very compelling, is whether or not the majority of these women with severe incontinence symptoms actually had fistula. And I know from ongoing work from colleagues who are fistula surgeons and from experience working in fistula service systems that many women do arrive with severe incontinence, but they do not have a fistula. So in reality, what we have here is a correlation of severe incontinence to gender-based violence, though we may infer that a significant portion of these women do have fistula. And it's interesting, if you look at our own data in countries that have had the luxury of looking at survivors of child abuse and particularly child sexual abuse, they almost always have some adult, persistent, chronic bladder or bowel dysfunction, very often incontinence, and there have been some theories about neuromodulation associated with sexual violence. So I'd like to turn it over now to Vandana. And Vandana, with that clinical lens in mind, you point out that we need more data before we can say that fistula may actually cause or aggravate gender-based violence. But has there been any research, particularly public health research, that suggests that other maternal or reproductive health morbidity may aggravate or cause GBV?
Thanks, Lauri, for that question, and also for putting, of course, the findings in that clinical context, that maybe what we're seeing is it's association between many kinds of severe incontinence and this increased experience of sexual or physical violence. So the fistula literature is really limited, but there's one paper in all of the research that I was trying to do when we were looking at this issue. There's a really interesting paper in Bangladesh that looked at violence against women with chronic maternal morbidities. And of course, because fistula is more rare, most of these women had pelvic organ prolapse that was in their history and their description associated with childbearing. And it was profound. This was qualitative research, a small number of women, but just really sad, but very, very significant increase in emotional, physical, and sexual violence in their feeling because they couldn't fulfill their roles. You know, with prolapse because of sort of the discomfort or the bulging and not being able to do certain kinds of physical tasks, not being able to have sex as expected, and really reporting an increase in abuse, all kinds of abuse because they were disabled by this morbidity. So I think that tells us that there's a plausibility here, that if you're experiencing really severe forms of incontinence or fistula or prolapse, and you are then more vulnerable to being treated badly. And I think it tells us also that when we provide services for these conditions, they have to be more holistic than just, quote, the repair, right? That they have to include counseling, potentially other, you know, looking at the mental health effects of being treated this way for potentially many years. So I think we have some questions coming in. And and Ellie, our fearless logistics person, organizer here, has actually pulled them out. So Lindsay, I think that many of these questions are going to come back to you, to the analysis, and I think you're still unmuted, so you'll be able to respond. So one question we have coming in, just taking us back to the overview of methods, how are we defining gender-based violence in this analysis? What kinds of violence are included in the definition for the questions that are asked in the DHS survey?
Great. So we have several types of violence that we're including. So it's whether or not a woman has ever experienced physical violence in this, or sexual violence, and this could come from a partner. We do have part of the domestic violence that is focused on married women. We also have separate questions that ask about violence that also occurred not necessarily in a relationship. Let's see, so we also include whether or not they experienced violence during pregnancy, and whether or not their first sexual experience was violent or an assault or not consensual. And then there are also questions that are related to violence if it had occurred within the 12 months prior to the survey.
Lindsay, I'm just wondering if the question might also just be trying to understand what kinds of actions or behaviors would be considered violence. Does the survey explain that to women? Does it give sort of an array of examples, or is it a pretty open-ended question that lets women themselves define what they consider to be violence?
It says any forced act, if I recall correctly. It doesn't specify what those acts could be. Sexual in nature, I think. I don't remember the exact wording offhand, but the domestic violence module is actually available online if anyone is interested in looking at those questions specifically.
Thank you, Lindsay. Then we have another question. I think this could be interpreted a few ways. The question is, what about Uganda with higher incidence of fistula? So I'll interpret first as, let me say one thing, is that the nature of the analysis, to get sample sizes big enough to do the kind of analysis with multiple variables that Lindsay described, we were not looking at associations separately in each country. Lindsay, would that be correct? In other words, we're not able to make any statements about the specific association between violence and fistula in, say, Uganda. Would that be correct? Or is there anything more specific we could say? And Uganda, I think, is always of interest because it reports the highest prevalence of fistula symptoms compared to any other country in the DHS surveys.
Yeah, that's correct. We didn't look at any specific country in our multivariable regression analysis.
Right. And not, again, to the question, the person asking the question, I think this also speaks to why qualitative research is really important, because we won't, we'll really never have big enough numbers to do this kind of quantitative analysis country by country, but we can explore what is going on in a setting where more women are reporting these symptoms. We have 2 more questions that are methodological. So I'll read them to you, Lindsay. Was fistula data collected in all 12 countries reported here? And how is wealth associated with fistula? So back to you.
Great. Yes, so fistula, all of these 12 surveys that we used included these standardized questions on fistula. So we do have that information and more information additionally that's available from that module for each of these 12 questions. Wealth was actually not at all significantly associated with fistula.
Great, thank you. We have a question that directs back to the Fistula Care Plus program. What are the prevention components of Fistula Care Plus? And here I assume you mean prevention of fistula, because I think at this point we could not say that we're preventing GBV. It's not been something that we're targeting specifically. I think this research was an eye-opener for us. In terms of preventing fistula, we look at this in a number of ways. Family planning is a big part of this project. Preventing, helping women meet their own needs and desires for family planning helps prevent fistula, because of course, even with this increase that we see in iatrogenic fistulas or other types of fistulas, the majority are still caused by inadequately managed, prolonged, and obstructed labor. And so helping women plan their pregnancies, time their pregnancies is a big part of fistula prevention. The prevention component in our program also includes community education and mobilization around using skilled care delivery, around recognizing a prolonged and obstructed labor quickly, around feeling comfortable with health facilities. We do work where community members do what are called site walkthroughs, for example, where they really have an opportunity to interact with the health system, to understand what services are available to them, and to talk about the barriers that keep them from using healthcare. So those are some of our prevention components, and I would encourage anyone who's interested in learning more to visit the Fistula Care website, and we'll show you the link at the end. But there's a lot of information about what we've been doing there. And when it comes to women who've actually come to facilities to deliver, a huge part of prevention is adequate monitoring of labor and recognition of obstructed labor. So we do train nurses and other health providers in using the partograph, which is an essential part of skilled care at birth. And that helps monitor labor, recognize obstructed labor, and do something about it. We have one more, huge question, and I will take a stab at it, but everyone who's on this call would have an amazing thought about the answer to this, and I wish we had a way to let everyone who's on the call speak in response to this. It's the $1,000,000 question. Additional thoughts on how social and gender norms contribute to GBV and fistula? And I think I might say something and then turn it over to Lauri on this, but if what we mean by gender norms are norms that devalue women and devalue girls and don't create an environment of respect and empowerment for all community members, and we could see that the value of skilled care at birth, or the value of care seeking when complication arises, could be low. And perhaps there's a sort of constellation of risks that happen if women and girls just viewed as equal, or viewed as equally worthy of respect, empowerment, and protection. I don't know, Lauri, if you want to say anything more specific on how the same gender norms might be contributing to fistula that contribute to GBV as a clinician.
Yeah, it's a very challenging question, because it's difficult to avoid socioeconomic status bias when you're answering this type of question. But I'll restrict my response to the countries that we're working in, and specifically to Congo, where we've seen not only a devaluation of women related to conflict, but also that this conflict-related sexual violence has escalated and malignantly expanded into civil society, so that now sexual violence perpetrated by police, by the military upon the population they're supposed to be protecting, by neighbors on neighbors, by husbands on wives, by schoolmates on female schoolmates is increasing. It's tragic. It's excruciating to see, and reversing that horrifying trend, I think, it crystallizes all of the issues that we're considering. And it really is about valuing the feminine and valuing girls and women as the embodiment of the feminine. And then we get into a feminist analysis. I think that's really beyond the scope of our webinar today, but I do appreciate the opportunity to answer that question.
Thank you so much, Lauri. Another question we've received is, are there any examples of fistula programs that screen for GBV? I think this is a really important question. If any of the participants on this webinar are involved in fistula service programs themselves and have any experience with screening for GBV, please let us know in the chat box and we will try to follow up with you. What I will say is that we are going to survey our supported sites and understand which of them are currently screening for GBV, which of them have any ability to refer to services for this. I think that it is not really for any healthcare, for any maternal health program or other public health program. I don't think we have really successfully integrated GBV across the board. There are examples at EngenderHealth of family planning programs that are integrating GBV issues, but we will be taking a look at our supported sites for fistula services to understand what's happening right now, and we hope to report that back, to share that back with you. But again, if anyone on the chat does have any information about this, please let us know, and we'd love to hear about your experience. We have a couple of more comments, and then we're going to kind of shift into wrapping up. I will read this, and then we'll do our best to respond to the concern here. Fistula is common among young women in northern Nigeria. You glossed over age in your analysis. Is it not right to include fistula from prolonged and obstructed labor among minors as a variant of sexual and gender-based violence? And so to unpack that, it's sort of two separate questions. One, and we might kick back to Lindsay, which is, can you remind us about the associations found with age? And then perhaps I'll ask Lauri to talk about the second question, which is really, if minors, if girls are becoming pregnant and those girls are getting obstetric fistula, isn't that a kind of GBV? So Lindsay, can you respond to the first part of that about age and the associations?
Sure, yes. So age was significantly associated with having fistula at both the bivariate and multivariable levels. However, it was older age groups. So we categorized age into three groups. So the first group was 15 to 23-year-olds. The second group was 24 to 32-year-olds, and then the third group was 33 to 49-year-olds. And we did that based on the distribution of age within our sample. And what we found was that for both ever experience of violence and recent experience of violence, both the two older age groups were significantly more likely to report having fistula compared with the 15 to 23-year-olds. And I think that, and from what I'm seeing, I think that links to what Lauri was mentioning about how the older age groups and the higher parity have had these difficult childbirth. I'm sorry if I'm not saying this correctly, but maybe Lauri or Vandana can help with this after. But these older age groups are more likely to have incontinence, not necessarily fistula related. So that's what we were seeing with our age in our analysis.
Thanks for that nuanced explanation. And that's a really great point that with age, of course, all the other kinds of severe incontinence that women might be conflating with fistula will be more prevalent. So I want to see if Lauri wants to offer any comment on the second part of that question, though, of, if we're looking at younger girls getting pregnant and having obstetric fistula, is that a kind of GBV in itself?
Yes, thank you, Lindsay and Vandana. That really is a question that you have to look at through the lens of cultural norms and traditions. And as such, it's extremely difficult to answer that question But let me give some historical analogies and also take into perspective the possible perspective of the questioner, because in the north of Nigeria, we have girls who were married at 9 and having a baby at 10, 11, 12, well under the age range captured by the DHS. And also in fistula surgery facilities, you do see this bivariate. You usually have more than half of the patients with an actual fistula diagnosed in a fistula service facility will be mature women, mothers of many children, very often 4 or more children. And it's possible that their obstructed labor, if their fistula is from obstructed labor, so we'll restrict ourselves to prolonged obstructed labor for this response. Those women are older. The older you are, the larger the birth weight of the baby tends to be if your nutrition is normal. You also are more likely to have multiple gestation, or there may be other factors such as a fibroid that wasn't there when you had your babies at 15, that is there now when you're having babies at 35, that's contributing to the baby not coming out. So actually the majority of women in fistula services where we're not restricted also at the upper limit of DHS at 49 years. We get women of all ages. The other large group, at usually somewhat under half, are women who have a fistula associated with their first pregnancy. Now these women in general tend to hover around a mean or median age of around 18, but you do get that younger group, those true child brides in that group, where their pelvis is just small, and their pelvis is small even at the age of 23 or 32 whenever they have that first baby. But if they're having that baby with an immature pelvis, because a woman's pelvis doesn't mature in size until about age 15 or 16, so if she's under 15, she truly has probably not reached her true pelvic parameters, and she may have a small pelvis and the baby may get stuck because it's simply too small to let the baby out. However, I just want to point out that in the United States, if you look at our census, our own health data, we have, for many years it was around 10 to 12,000. In the last data set published by Health and Human Services, it was around 8,000 girls in the United States under the age of 15, not yet age 15, giving birth to babies, and none of them have fistula. And what this speaks to is simply that when you have adequate maternal health services and the communities are comfortable and have faith in those services and they have access to those services that is reliable, even a 12-year-old who we don't want to be having a baby, we possibly don't want her to be married and making babies at 10, 11, 12, but if she does, she's not going to end up with a fistula. And if you look at the history of eradicating fistula in North America and Western Europe, it was done at a time where child marriage shortly after menarche was very common, and there was no birth control, and women still were following a traditional model, and having many babies was a source of true social currency. So there was immediate childbirth, frequent childbirth, childbirth, and yet in that environment, fistula was eradicated in the early 1900s. So when we talk about child brides, the tragedy, if you consider it a tragedy, is simply that children are getting married rather than being in school and having babies, and then it's the health system that's failing them if you think about it. And if you look at wealthy nations, even the United States has not managed to eradicate children having children.
Thank you, Lauri. I think that was a really helpful exploration of the intersection between cultural norms and practices, but also health systems, and a reminder that the same risks have different effects in different settings. And I appreciate that, because one question that we had pending was, obviously GBV is global. It's not just restricted to low and middle income countries or any region. It's happening in every wealth quintile. It's happening in every educational group. It's happening in every country of the world. So why not fistula? And I think you're just reminding us that it's about access to health care. It's about emergency cesarean sections. It's about adequate management of the childbearing experience. We have one more question that I really do want us to get to. We're almost out of time. But the question is, I could not recall the list of countries where Lindsay analyzed the DHS data. So Lindsay, I'm going to ask you to just remind us of the countries that were included in the final analysis, and then we'll come back to part 2 of this question.
Sure. Do you want to go back to slide 16 that has the list of the countries or the prevalence by country? I don't know if that would be helpful.
Great. Yes. There we go.
Yeah.
So Cameroon, Comoros, Kenya, Malawi, Mali, Nigeria, Sierra Leone, Tanzania, and Zambia. And the context, the part 2 of the question was about female genital cutting and how are we able to distinguish between GBV and the genital cutting association with fistula in countries where genital cutting is highly prevalent. Many thanks for the great presentation. Thank you for your feedback and for your question. I think this issue of female genital mutilation and cutting and fistula is interesting. Just a side note, in several countries where we've looked at the etiology, the cause of fistula cases at facilities we support, we do see a number of cases where mistakes during female genital cutting, in other words, an unfortunate slip of the knife, essentially, where mistakes during planned female genital cutting have actually led to fistula. And we have a healthy debate among our community about whether that kind of fistula should be considered traumatic, in other words, caused by violence, caused by injury, or whether it should be considered iatrogenic, because in some settings, of course, it is actually medicalized. Health providers are doing FGM, FGC. Now, Lindsay, I don't think we really have the ability to talk about FGM, FGC in your analysis because it wasn't included in the questions, but I could be wrong. Is there anything you'd want to add about what we know about GBV versus FGM, FGC in the women reporting fistula symptoms?
Sure, and I'm grateful this is coming up because I wanted to point out again what you mentioned earlier about that supplementary analysis where we did look at FGM and sexual violence, the association of sexual violence by country at the bivariate level. So that supplement that Vandana linked to has some of that information, right? So that hopefully that can also address an earlier question. We did not look at FGM in all of these countries in this analysis, though, because those questions aren't available in all of those surveys. They're probably available in maybe half of the countries that are included in this survey. But if you are interested in looking at some of those bivariate relationships, they are available there.
And I've got the link up here, but for anyone who's interested, if you just even Google DHS survey, DHS program and fistula, you'll find these reports. So this has been such a great discussion. We really, really appreciate all of your questions and comments. I'm going to hand it back to our moderator to close us out. And Lauri, here we go.
So I want to thank all of the participants and also our presenters, Vandana and Lindsay, for a robust webinar. It's morning here in New York. I'm sure for many of you it's no longer morning. And also to take the opportunity to have an EngenderHealth commercial. On March 17 of this year, EngenderHealth will be sponsoring an event during the UN Commission on the Status of Women's meeting here in New York on women's economic empowerment, a driving force in violence reduction and improved health outcomes. There is a web link there.
Yeah, and we'll be able to, if you're interested in this, please visit the EngenderHealth website and you'll see more information about this. Save the date, the Women's Economic Empowerment event on March 17th.
So with that, and I don't know, do we have any questioners that didn't get their questions answered?
I think we
covered everybody. Lovely. Thank you, everyone, for a very successful conversation on the linkages between severe incontinence that may well be fistula and gender-based violence. Have a good evening.
Thanks, everybody.
Thank you.
Thanks, Lindsay, especially.
Thanks to you guys, too.
Bye-bye.